Good afternoon, everyone, and welcome to UCSF Family and Community Medicine Grand Rounds. Our presentation today is person-centered approaches to sexual and reproductive healthcare delivery through the lenses of health equity and racial justice. And our presenters today are Deanna Carvajal and Rachel Logan, who we're very excited to welcome. But before we get started, just a few announcements. Today's session is recorded. And if you'd like to see today's session again or see prior sessions that you may have missed, you can check us out on the UCSF Department of Family and Community Medicine Grand Rounds website. All the sessions are uploaded and available about 3 days after the session happens. So please look for us there. I also want to say thank you to our wonderful tech team today. Roy Johnston, Benjamin Wallen, and Erigo Mitchell. We're glad to have your support. Thank you so much. Today's session is really designed to be an interactive one, so we hope that you'll use the question and answer box in your chat in order to ask questions of our team or send your thoughts or suggestions. We'll have time for Q&A at the end, so please use those. And as always, if you have suggestions about today's Grand Rounds or feedback or ideas for other Grand Rounds, or you want to come speak at Grand Rounds, please let us know. You can reach out to us here in Family and Community Medicine. There's an evaluation in the chat, and you can also message us directly. With no further ado, I will get us started with today's presentation, which for those of us who just joined us is called Person-Centered Approaches to Sexual and Reproductive Healthcare Delivery Through the Lenses of Health Equity and Racial Justice. Today's presentation delves into the critical issues of health equity and racial justice within sexual and reproductive healthcare. Today, our presenters will examine the historical and structural roots of injustices in sexual and reproductive health, shedding light on long-standing inequities in health delivery and care delivery. Through personal narratives and contemporary examples, our presenters will discuss with us today how individuals with socially marginalized identities navigate the complexities of sexual and reproductive health care. Sharing insights from a family physician and a public health researcher, today's team will draw from data and lived experiences, and together we'll underscore the pressing need for systemic change, beginning with strategies for the clinical community. Our presenters today, who we're very excited to welcome, include Dr. Deanna Carvajal, who is an associate professor and a practicing family physician and a health services researcher in the Department of Family and Community Medicine at University of Maryland. She's director of reproductive health education within the department's residency program and also co-leads the department's research division. In her research, Dr. Carvajal focuses on addressing reproductive health inequities for the most disadvantaged communities and employs lenses of reproductive justice and intersectionality to understand how clinicians can best support and communicate with their patients about important reproductive health care decisions. In addition, she's also the director of diversity, equity, inclusion, and strategic planning for the Ready-based program at Montefiore Albert Einstein Medical College in Bronx. Our second presenter today, who we're also very excited to welcome, is Dr. Rachel Logan. Dr. Logan is a research specialist who completed a postdoctoral fellowship in the department and has a background in public health. Her work centers Black and other socially marginalized communities in strategies to improve sexual and reproductive health and healthcare experiences. She lives in Florida and is committed to realizing health equity and racial justice throughout the U.S., particularly in the Southeast. I want to welcome our presenters today. Thank you so much for joining us.
Thank you so much, Dr. Benner. Deanna, can you advance the slides? So we have no conflicts of interest to disclose. And I will invite Dr. Carvajal to share her positionality.
So hi, everyone, and thanks so much for having us. It's definitely my privilege to be here today and appreciate the invitation. I am Deanna Carvajal. Aside from the professional positionality that was shared, I will also share my personal positionality because I think it's important when we deliver these kinds of talks, that you have an idea of where I'm coming from. So I am a mom and a sister, a daughter and a partner. I am Latina. Both of my parents are from the Spanish-speaking Caribbean. One is an immigrant, and depending on how you think about Puerto Rico, the other is not. I am also a first-generation college student, and I will say that much of the work that I will talk about here and that I focus on is really comes out of personal interest and experience and drive that's related to my own lived experiences and those of my family and community members as I grow up. And so that is my positionality that I wanted to share with you today. I will pass it back to Dr. Logan to get started.
Thank you so much. And as a Black cisgender woman from the Southeast, I bring that to my work. Grew up in a very conservative Christian household, but I was always curious around sexual and reproductive health topics. And I took that with me throughout my education, studying in public health, and then continuing my education, not from the formal health education system, but through literature and works of Black feminists, scholars, authors, Indigenous scholars, and others who share about the history of our country and kind of where we are and how we got to this place. And then learning from other folks in the community and those who may not have all the credentials and letters behind their name, but who are just as wise and experienced and knowledgeable. And so I appreciate the education that has offered me. And I continue this journey of learning as I go through my work to improve sexual and reproductive health care for folks with socially marginalized identities. So for our time today, we will give a very brief quick overview of some of these historical roots of sexual and reproductive health injustices. As Dr. Carvajal states in some of her talks and work, this is a privilege to have this moment in time where we gather and learn about this history that isn't always so accessible in our systems of higher education. So it is a gift to have this opportunity to learn some of this, discuss it in this forum. We also will describe some of these contemporary examples and define person-centered care and consider the ways that we can leverage that as we move forward to achieve racial and health equity. And so while we were informed that this is a very diverse audience, not just folks from family medicine, and as someone outside of that discipline in their formal training, I think it's really helpful to reflect on the promise of family medicine and what it was meant to do and to offer us as we consider how to improve sexual and reproductive health care. And I have the privilege of working in a department of family medicine and learning from folks who are reminding me that the roots of this discipline are in social justice, and it needs to continue on as we move forward. And some of these nuggets we can take with us in other areas like public health and other social sciences and clinical disciplines. So around the time that family medicine came to be in 1969, this was also the time of the Vietnam War, of the Civil Rights era, of other social and political reckonings occurring in our nation, similar to the space that we find ourselves in today. And early folks really believed that family medicine could be the answer to offer more personalized, integrated care and services to members of the community, drawing from community resources. So it was a different clinical medical paradigm that was being offered here. And in part, the American Academy of Family Physicians says that it encompasses all ages, different genders and sexes, and also different organ systems in every disease entity. And while that is that large mission and vision, there are some gaps that remain in the services that family physicians offer. And in this particular study of about 6,000 recent family medicine residency graduates, they reported that overwhelmingly they were trained to offer sexual and reproductive health services. But as you can see here with that navy bar, the actual practice of offering the service within 3 years of graduation is quite low, especially as you move closer to the right of the chart, where you see pregnancy termination, abortion type services. So even though this is a part of that overarching whole person approach to care, there are some ways that we can improve service delivery and provision. But most importantly for our conversation today, we're talking about improving the quality of care. So even more SAGE people might offer more of these services, but we're very interested in improving that overall quality and offering high quality care continuously. So in order to understand these potential gaps, maybe the lack of scope and robustness of these sexual and reproductive health services, and also why our healthcare system is kind of set up the way it is, we can go into the history a bit more to learn from that. And so 2 dates I'm calling up in this space are 1492, which is when the first Europeans arrived at these shores, and that began the murder and pillaging of indigenous bodies and land. And the dispossession of indigenous lands ushered in the colonists taking over and displacing hundreds of thousands of people. Also later, about 200 years later, in 1619, the first enslaved Africans were brought over in order to work and labor on plantations. And for about 200 years, we have this system where people are dehumanized and only seen as a product and a means of production. And in 1819, in Virginia, the state where I'm from, they decreed that every person born to an enslaved woman was a slave. And that was a very particular, very pernicious and poignant policy, because as slavery or the transition of human cargo across the ocean ended, there needed to be a way to continue to fuel the slave trade. And that was through Black folks' bodies. And so now America became very, very interested in ensuring that Black people would continue to reproduce to bolster the workforce. And in more of a economic understanding, paying for an enslaved person, especially if they had pregnancy capability, meant that any offspring were then slaves, and often the offspring were worth more than the person who gave birth. And here is a timeline of just a few more touch points that really shape our view of reproduction and of certain people's bodies. So that stratified reproduction element, uplifting the Indian Removal and the Indian Removal Act and the Trail of Tears, which further dispossessed and displaced indigenous people, but also it subjected pregnant and birthing people and children to untold harm as they made that trek in winter without any resources, food, and so many people died along the way. And even after they arrived at their destination, there were ongoing efforts to assimilate what the term the colonists used were savages. And so family separation became a part of the state's function, where indigenous children were forcibly removed from their homes and replaced with white families, where they learned about Christianity, were stripped of their culture, their language, any ties to their ethnic and cultural identity. And that idea of family separation and it being okay for certain people to not have the privilege of parenting their own children is something that remains with us today. We see it through like Child Protective Services, Department of Children and Families, where certain groups, mostly Black and Brown folks, have this overstepping by the state. And then in 1882, the Chinese Exclusion Act was one of the first policies that specifically named a racial or ethnic group and their exclusion. So they were not allowed to migrate or immigrate to the United States. And those who were here were barred from starting relationships with the locals, or most importantly, with white people, because they wanted to ensure the purity of the white race and didn't want to have any type of miscegenation. And that narrative that was used to vilify and demonize Chinese in particular, but other Asian immigrants, was very similar to the language that was used once Black enslaved folks were emancipated. And while their production previously, or their reproduction previously, was privileged and it was advantageous, once they became free, now they were viewed as hypersexual, as very lewd, as being lustful people. And that same rhetoric was used repeatedly. So there's some interconnections, even though we're talking about different groups. And then calling up the development of the birth control pill as a pivotal moment in our history, where, as I believe Dr. Emily Mann speaks about, that contraceptive paradox, where on the one hand, the oral contraceptive pill is going to, as Margaret Sanger intended, to like emancipate women, to free them from this burden of constant reproduction. But on the other hand, is used as a tool for eugenics and for that to proliferate. So middle-class white women who are affluent now have this power, whereas other people, they are thought that their reproduction shouldn't occur, and these birth control pills are now infiltrating these communities. But even before that, the development of the birth control pill took place in areas where they weren't approved to do the testing. So places like Puerto Rico, also some testing in Mexico and in Haiti, where those early iterations had high levels of hormone. It was administered to people without their consent. People may not have been compensated or aware of what they were being given, and that increased illness and infertility in some of these communities. And then since that time, there has been continuous policies and enactments that have barred access to sexual and reproductive health services, restricted people based on social or personal identities, on economic factors such as the Hyde Amendment, where federal funds, in particular Medicaid, cannot be used for like abortion services. And then there are many more historical moments that shape this moment that we're in today. And Dr. Carvajal will speak a little bit more about that in a moment. But also considering that not only are these events happening through our legal system in our communities, in the actual healthcare space, harms, criminalization, or penalizations are occurring as well. And early birth workers, like our lay healers, midwives, other birth attendants, were the folks who initially offered us those services to help us through pregnancy, to help us through birth, and also were some of those early abortionists. And that lay knowledge that was built into communities, had a lot of cultural roots, was lost once we started to have this prominence of the physician model of care. So folks like J. Marion Sims, who was previously lauded as the father of gynecology, we now know that he extracted knowledge from midwives, lay birth workers, and also experimented on Black and brown bodies without their consent, doing unnecessary procedures without any pain medicine or management. And so that extraction of knowledge and resources from one discipline to bolster another, while that grows, becomes more prominent, and is now seen as a profession of prestige, we have medicalized care in a way that disadvantages, one, a whole entire workforce, but two, the people who were able to relate to folks in their community and have those cultural services. I use the term sexual and gender minority health, but of course, at the time or in our early history, that is not the view of the care, if one could even call it care at that time. So people were viewed to have psychological disorders. They were given unnecessary, if not harmful, treatments. institutionalized because they had different identities or had same gender lovers. People use conversion therapy, as well as just overall denying people gender affirming care, as well as basic care and services. And then another component of this healthcare divide that has contributed to our current moment is the increase of reproductive technology, but also the widening gaps in who can access these technologies. And one of those key vehicles is limiting health insurance coverage for things like infertility services. And so we have these stark class differences in who can get this kind of assistance, and who is viewed to be worthy of this kind of aid and help. Whereas if you have a Black or brown person, if they are not able to give birth or be pregnant, it almost is viewed as like the will of God, that they aren't worthy or deserving of that assistance.
Okay, so I'll transition over now. Thank you, Dr. Logan. The history that Dr. Logan discusses and brings us to modern day, I think, is really important in understanding really how we get to where we are. And so I'm going to talk a little bit more about some modern policies and practices in sexual and reproductive health to just bring us a little bit closer to where we are now. Importantly, I'm going to start by talking about some of the first long-acting contraceptive methods to come to the market in the US. And these come about in the 1970s and 80s, and even in the 90s, when we start to see, again, how fertility, again, starts to come to the forefront as something that we are really trying to control. And we'll see how in medicine, we start to join legislators and policymakers in having that control. So in the 70s and 80s, maybe some of you are familiar with the Delcon Shield IUD, which is one of the first IUDs approved for use in the US. So it's this polyfilament IUD. It had this long string and actually ends up being associated with significant reproductive harm, including sepsis, uterine puncture, infertility, pelvic inflammatory disease. But importantly, was really marketed specifically toward low-income folks, particularly Black and brown folks at the time. Also emerging at that time, a little bit later in the 1990s, is Norplant. And Norplant becomes really popular and is specifically used as an incentive to reduce or avoid incarceration in mothers accused of substance use or child abuse, or anyone who is deemed, quote unquote, not responsible enough to be a mother. Eventually, we see, for a number of reasons, that Norplant is pulled from the market. But relatedly, and around the same time, in the 1980s, and specifically in 1987, is also when we start to see that US officials in particular are administering DEPO. Just like Dr. Logan talked about what happened in Puerto Rico and Haiti and Mexico with the testing of contraceptives before they're FDA approved, the same thing happens in the 1980s, specifically geared toward Native American women who at least 50 of whom are deemed, quote unquote, mentally impaired. And from that time, even when DEPO does finally get approved, we start to see really in high frequencies DEPO being administered across public health clinics, particularly to low-income folks and without adequate medical information and consent. In the 90s is when we start to see legislative proposals make public assistance benefits contingent upon contraceptive use. And this one is really important because as public assistance is tied to contraception and to fertility, we start to see campaigns and policies that lead us to modern day perceptions of the relationship between poverty and fertility, and how poverty in particular gets inextricably tied to reproduction, which turns out to be really important because we begin to adapt that thinking not only in our legislative policies, but also in our clinical guidelines and in the practices and policies that we carry out. And so on the right here, I have some headlines to kind of bring us into modern day of some pretty contemporary headlines that relate contraception to poverty reduction. But even though while these are really quite contemporary, contraception is actually touted as a poverty reduction method, at least since the early 20th century. It does get revitalized with the LBJ administration and even goes global, right? So it becomes part of the 8 Millennium Development Goals, or the MDGs, in 2000. And these anti-poverty innovations that are related to contraception and fertility are actually met around across the globe with lots of philanthropic giving for decades, even leading up to today. So the Bill and Melinda Gates Foundation, as well as the Susan Buffett Foundation, and many of these foundations with lots of money really start pouring their resources into contraception and fertility control as a method of poverty prevention. And it's still widely discussed, contraception and fertility, as a method of poverty reduction now across the globe, particularly in low and middle income countries, particularly those in Africa and Latin America. And so while we know that simply facilitating a way for people, particularly certain people, to have fewer children is not going to address the underlying structural and systemic racism in America that's actually associated with poverty, we still do it. And we see it embedded in much of the work that we do now. We know that social, economic, and political injustices have existed for centuries and are now institutionalized. So thinking that contraception or fertility control is somehow going to reduce poverty really doesn't take into account historic and current injustices, right? Like unequal housing, healthcare, education, food, imprisonment of certain populations, abuse by police. Yet we subscribe to these things not only legislatively, but as I'll show in the next couple of slides, also in our policies and our practices. And what we're actually doing is perpetuating more reproductive harm and human rights violations, particularly for marginalized populations. In more recent examples, and this is particularly related to legislation or attempted legislation at fertility control, and these are their headlines here, and I'm not going to spend a ton of time on each of them, but I bring them up as very recent examples of how our legislation is really tied to reproduction and how it's really targeted those who society deems should not be having children. Not that different from all of the historical background that Dr. Logan gave us. It's a focus on poor and low income folks, on folks of color, on those in prison, and those who are disproportionately Black, Indigenous, or Latinx folks. And we see that these efforts to continue to force or coerce contraception or sterilization practices persist in legislation and the penal system, and undermine and specifically devalue the childbearing of some, while effectively forcing childbearing on others. This is not that different from what Dr. Logan was talking about as something that happened in the past, but actually is still happening. The first headline is from 2008 that shows that a Louisiana lawmaker proposed public assistance recipients get $1,000 each to either have a tubal ligation or to have a vasectomy, and at the same time is also proposing tax incentives for college-educated couples to have more kids. From 2006 to 2010, I'm sure most folks are familiar with this if you're in the state of California, we know that California prisons sterilized at least 148 prisoners who were pregnant while they were housed in the prison, and who were seemingly coerced to do so and to accept the procedures, because these procedures are normally required approval from top medical officials, but that approval was actually not obtained. And probably not shockingly, this happens disproportionately to a group of people of color. And then finally, my last headline is from 2017, which is 7 years ago, where a Tennessee judge offered to reduce jail time for those who got the contraceptive implant or underwent vasectomy. And I bring these up because I think it's important to understand that these relate to what we do in healthcare as well. It's not just something that's happening outside of the space of healthcare and public health. In our policy, in our practice, notably for at least a decade, sexual and reproductive health practice has strongly pushed or promoted long-acting contraceptive methods, right? We've done this in the name of access. That's what we have been saying, but it hasn't always been so equitable, just, and least of all patient-centered. So in 2014, and I remember this vividly when these came out, the CDC and the Office of Population Affairs at Health and Human Services comes out with this document called the Quality Family Planning Services Document, or the QFP. And what this document told us about contraception counseling was that we should assess patient preferences above all else. But then it also went into talking about how a tiered effectiveness approach, or an approach that specifically counsels first and foremost about the most effective methods, is the way that we should go. And that was potentially problematic for lots of reasons, not the least of which is that it prioritize effectiveness in preventing pregnancy, which was the thing held most importantly by us in sexual and reproductive health and public health, but not necessarily the patient preferences. It encouraged a clinician to specifically focus on counseling only or mostly about long-acting methods first, and notably leads to perceptions of an actual coercion of specific populations, notably low-income folks of color, to use LARC methods over other methods, even when they didn't want to. And obviously ends up not accounting for centuries of medical abuse and mistrust of marginalized populations. And so those examples that I just shared of how legislation and government initiatives and other policies and even our clinical guidelines and recommendations eventually impact practice lead us to some of the data that we see today, right? So for instance, in our contemporary context, we know that sexual and reproductive health access is not experienced equitably across populations, right? So Black and Latina or Latinx patients report that they are more often compared to white patients coerced into using long-acting methods, that they have shorter visits discussing sexual and reproductive health, and that they often feel a clinician desire to restrict their childbearing. These same folks are also less likely to report patient-centered care or an understanding of the method, the contraceptive method that they choose or that they're using, not because they don't understand the method or don't understand the education behind it, but because they don't have the time or the communication with their healthcare providers that others do. When we consider LGBTQIA+ patients, we know that 1 in 3 patients are turned away for healthcare, including sexual and reproductive health. 1 in 3. And we also know that this group is also more likely to report discriminatory comments and treatment in sexual and reproductive health, and a lack of provider competency to take care of them. And when we look at the data for patients with disabilities, we also see that patients with disabilities of reproductive health age report significantly limited healthcare professional competency and quality of care. And that ranges from a whole host of reproductive health issues, from contraception to menstrual management to pregnancy and to pelvic exams as well. And so looking at this data, we could say, you know, what we had this history, and now we have, unfortunately, still some inequity and some legacy and some coercion. But actually, what we're seeing is really an extension of generational trauma, of violence, some of it intentional, some of it concerted, and in some cases, government sanctioned, right? And very much inspired by and within a framework, right, that really thinks about whose bodies and reproduction are valued and who's mattered and who simply do not. And that carries over into the care that we're doing in healthcare. And so as healthcare professionals and the systems that we work in and operate in, we are not exempt, right, from blame and from carrying out some of the very same oppressions and inequities and values that we claim to be against, and that we're in family medicine in particular trained to provide. And so as we discuss contemporary inequities and how we get here, I would be remiss not to mention the Dobbs decision and how things could potentially get worse, right? And so we know that inequities are gonna get worse, that they will persist, that the majority of people in particular who are seeking abortions are also facing structural and systemic racism and social and political inequity. And that in addition to that, those that are most affected by current restrictions are people with financial and logistic barriers, Black, Indigenous, and Latina and Latinx folks, and other folks of color, young people, people with disabilities, LGBTQIA+ folks, and those people that live in rural areas. And so with that, in the context of the Dobbs decision, what can we expect for sexual and reproductive health, particularly pregnant folks, right? We know that pregnancy-related morbidity and mortality is going to get worse. It already is. Most states that are hostile to abortion rights are those already with the highest maternal mortality rates and the highest infant mortality rates. And beyond that, what worries me the most really is that we can expect an increase in criminalization of all pregnant people with so many aspects of sexual and reproductive health, especially Black and Brown folks. We know that the disproportionate criminalization of pregnant people has been a thing since way before the Dobbs decision, but we also know that it's going to get worse. At least 45% of all adult criminal cases related to pregnancy care are brought to the attention of law enforcement by healthcare professionals after interactions with patients. Let me say that one more time. The majority of folks criminalized because of their pregnancy for any reason have been brought to the attention of law enforcement by medical professionals who basically called the cops. And we know that these policies that criminalize folks before, during, and after pregnancy are just serving to discourage them from getting care that they need at the time that they need it. Additionally, when we think about Child Protective Services or CPS, we also know that this really is focusing on marginalizing pregnant people disproportionately who are Black and Brown and other folks of color, that these are the very same people that are more likely to be reported to government authorities. And that Black and African American families are more likely to then be investigated also by CPS. And thinking about this, right, thinking about the criminalization, thinking about what happens with CPS, I really invite us to take a look inward at the harms that we do in our daily work and how at times we as healthcare providers and healthcare professionals, even in public health, all of us are agents, not just of a criminal justice system, but agents of our own healthcare system that really does a lot of harm to patients. And how can we start to think about changing that? And so to discuss a lot of that, I'm going to pass this back to Dr. Logan, who's going to talk about person-centered care in this very context.
Thank you, Dr. Carvajal. And there are many examples of the subtleties of reproductive injustices. And there's two articles I would like to mention here, both published this year. One is an investigative piece around coercion and unwanted sterilizations in people who have been diagnosed with sickle cell disease. And the other is around long-acting reversible contraception. And the first piece is rather unique because we know that more than 90% of people diagnosed with sickle cell disease are people with some type of African ancestry. So we have this history where Black and Brown folks, particularly Black folks, have been marginalized, have been deemed to be unfit to parent, shouldn't get pregnant and have their fertility controlled. And then you have this condition which overwhelmingly impacts them and their communities. And so you have this convergence of ways that we can easily tap back into our oppressive views and suppressing people's options, reducing their autonomy in this space. And for me, if you apply a racial and health equity lens, you would be more attuned to avoiding coercion. But because in many spaces in our country, we try to wish away racism, we try to wish away oppression as opposed to facing it, then you have these instances. So people describe these subtleties. They're not like overt ways of oppressing and forcing people to get unwanted sterilizations, but they're little nuances. The way that you talk to people, the threats that you give that are framed or couched in a desire to care for them, right? So one of the clinicians that consulted on the sickle cell story talks about, you know, the threat of death is always imminent if you have sickle cell disease and you're talking about reproduction and pregnancy. So if you refuse or don't adhere to a provider's recommendation, they tell you essentially, you need to do this or you will die. You need to do this or, you know, your child would have this condition. There's always this threat of harm or of a negative outcome unless you do what the provider says. And in this instance, strong encouragement for people to get tubal ligations and other sterilization procedures to avoid having any type of pregnancy, even when people made it quite clear they wanted to become pregnant. And this also doesn't align with the best science and evidence, but as a patient coming to a provider, you believe that person has your best interest at heart. And so people did agree to have these procedures. And so that is the complicated piece. In the narrative, I think they beautifully convey that the patients are saying, I did consent, but when they describe it, we realize that there were significant points in the quote unquote care that was provided where they were coerced or they weren't respected or given the full range of options. And then the other one where people were pressured into long-acting reversible contraception. Per Dr. Carvajal's statements earlier, I do think we might see an increase in these kinds of sentiments as the Dobbs decision came down. I started to hear more people talk about, well, then we have to get LARC in people's bodies, essentially. So LARC is going to be the option if they restrict abortion. And while that might be a solution, in no way should we pressure anyone to use any particular method, but these are sometimes those ideas or resources we return to when we don't have the answer, when we feel uncomfortable with some of the choices and decisions people are making. And while we've talked quite a bit on the reproductive side, just uplifting the sexual health side as well. And this was a campaign that was recently released from a Canadian health system where they're talking about the ongoing significant HIV stigma that folks living with HIV experience when they try to engage in health services. And so I thought this was such a great example of pushing back on some of these narratives that certain people aren't worthy of dignity and respect in care. So I encourage folks to look at the video, but it basically invites people to consider whether their doctor would need stigmavir, similar to tenofovir, the HIV prevention medication. But these are ongoing issues where we select certain groups within our society and deem them unworthy of dignity, respect, and care. And that comes out continuously. And even if you're not the provider who is perpetuating this harm, many of the people that come into your space, into your system, into your healthcare facility have had these experiences. So we have to be more cognizant and aware of how we don't perpetuate that harm, and we actually contribute to making the experience better for folks. And I also want to mention the ongoing concern around the bans on gender affirming care and what does that mean for healthcare providers? What do we need to start to consider and build and create to ensure that people aren't going to be overwhelmingly harmed? Like the harm is coming, but is there a way or are there ways for us to combat that harm, acknowledging that historically this is a population that has tremendously been harmed by our healthcare system. And when we use an intersectional lens, combining racial and health equity, what are some of the strategies to improve their care experiences? And so mentioning the definition of patient care, which I think we've kind of gotten away from, which is that preservation of physical and mental well-being. That is absent in many people's care experiences. And so a return to that was necessary given this heavy physician-based model, this paternalistic model of care that we initially had. But even more importantly was this transition to person-centered care. Next slide, please. Where not only do we consider that this person has autonomy, we should help them maintain physical and mental well-being throughout care delivery, we also should incorporate their preferences, needs, and values within the care plan. So the Institute of Medicine recognized this as a key component of care quality, highlighting that communication is a core component of offering patient-centered care. But we're taking that concept a bit further, applying our health equity lens to consider that not every person who seeks services is a patient. And initially, the definition of patient was one who suffers. And so when we just view people in terms of their condition or their disease, we strip them of their humanity and of their dignity. And so person-centered care considers that this individual has expertise and knowledge that they're bringing to the care visit. And with a trained health professional, a healthcare provider, they can chart the best course that aligns with their needs and preferences.
Okay, and so as we think about person-centered care, as Dr. Logan has just told us, I think very much about how it matters. And I think about it also in the context of what we even measure in medicine and in public health. Can we think about person-centered care in a way that can prompt us to think about the metrics that are really important for how care is delivered and how care is received? So as sexual and reproductive health care professionals and public health professionals, we might ask ourselves, within the context of the historic and contemporary inequities that we're seeing, whether or not we are using the quote unquote right metrics when we consider sexual and reproductive health, right? Especially around metrics related to fertility. We know that our maternal and infant mortality rates give us some important information about health, the health of people and their families, but what about some of these other metrics that we often tout as important, right? Wanted or unwanted pregnancy, planned or unplanned teen or adolescent pregnancy, right? We put these sort of in a binary as if there wasn't a continuum, and also uphold them as important metrics, right? And they're all related to people's fertility and whether or not they're pregnant or wanted to be pregnant, and why. What useful information does this give us? Why do we care so much? And how can we think about other metrics, right? And even when we think about these metrics, again, I'll bring it back to us linking it to poverty, as if these metrics were so important for us to eliminate poverty, even though we know they're not the root cause of poverty and may not even make poverty worse, as we have claimed in sexual and reproductive health and public health for decades. Instead, we know, right, that inequitable socioeconomic and sociopolitical conditions are the root causes of poverty. So as an example, because we talk about teen and adolescent pregnancy so much, economist Dee Gorey studied the effects of teen childbearing on education and labor market outcomes across socioeconomic status and race and ethnicity. And what Gorey found was that teen childbearing does lead to lower educational attainment, lower income, and greater use of public assistance, as we have been saying, right, for decades, but only for those from counties with better socioeconomic conditions. When Gorey looked at other teens, those living in counties with the quote unquote worst socioeconomic conditions, there were no adverse effects. So that across race and ethnicity, teen childbearing had negative consequences for white teens, but not for Black or Latina teens, right? And this really points to the notion that in this case, pregnancy for already disadvantaged teens and communities isn't the cause of poverty and or poor outcomes, and in some cases doesn't necessarily make things worse. In some cases, the paper showed it makes things better. But the years of systemic racism and oppression are the causes, yet we're focusing our attention in sexual and reproductive health and public health on pregnancy, intention or not intention, instead of the underlying causes and economic conditions that we know are deeply rooted in racism and all the other isms that you can think of, right? So that pregnancy and childbearing are not the oppressors, but maybe the legislative policies, the legislators of policies, and us as healthcare providers are actually the ones that are taking part in a lot of the oppression. And so I also think about measuring person-centered care and person-centered care as a metric. What do we know about it? What we know is that there's a lot of data that people who are seeking healthcare would love to have person-centered care, especially in sexual and reproductive health. What about clinicians? What do we know about clinicians? We know that clinicians claim to believe in the principles of person-centered care and that they deliver it, but do they actually do it? So there's a study by Manser and Bell from 2022 that looked at the extent to which sexual and reproductive health clinicians across the board practice person-centered care during contraception counseling and provision. And they specifically looked at early LARC removal requests and found that there was frequent resisting, delaying, and denying of removal requests. And that was happening disproportionately to low-income folks and to folks of color. In a study in 2021 that I participated in with some team members, we looked specifically at clinician perspectives about their own counseling with respect to person-centered care and Latina populations. And what we found was that they often touted the importance of person-centered care as being important, and they told us that they practice it, but then they also told us specifically of scenarios in the same sentence in which they were doing tiered effectiveness counseling and where they were spending time trying to quote unquote convince patients to keep methods longer, just as the first study showed, and that they even refused removal at times. And effectively, they were really focusing on the importance of, and they were prioritizing pregnancy prevention above all else, right? Even at the cost of true person-centered care, even when it wasn't consistent with what patients had expressed. And so what we really saw was this tension between this expressed desire to provide person-centered care, but then also this very paternalistic paradigm of prioritizing pregnancy prevention. And again, thinking about our roots and thinking about our history, why is it that we are so focused and care so much about the prevention of certain people, the pregnancy prevention of certain people and their fertility, while we are not focused on their actual experiences and on giving them what they need and ask for. This is just, and I'll do this quickly, this is just a quick quote from that study that, as Dr. Logan was saying, seems subtle, but the more you think about it and the more you read it, the more it feels less person-centered. So this is a clinician who says, I always make sure that they, my patients, know that they can always take it out, the LARC, if they don't like it. But I typically do encourage them to keep them for, like, commit to them for 6 months, and then we'll kind of work with the side effects issue, because sometimes I'll put them in and then I have girls come back like 2 weeks later and they're like, yeah, I've had bleeding for 2 weeks. I'm like, no. So thinking about making someone, especially an adolescent, keep something in their body that they don't want for a longer period of time, for 6 months, and then even then saying, well, let's deal with the side effects that you're having because we must prevent pregnancy. When again, our data and our outcomes do not show that pregnancy prevention or that having children and fertility is the problem. And so what can we do, right? What can be done? I invite us to really think about the implications of our oppressive history on the generational trauma and the legacies that affect patients and their communities, and how the current provision of sexual and reproductive health care, especially pregnancy prevention and pregnancy care, and the role that healthcare providers have in that really can make us potential agents of a healthcare system that is broken and significantly racist. Thinking about our past and current structural inequities and how they systematically target certain communities, I think is really important. Let's think about, for instance, the policies that we have around health insurance, who gets it, who doesn't, why and why not. For example, also, where are LARC campaigns happening, in what neighborhoods, in what zip codes, where are we really trying to expand contraceptive access? And instead, think about practicing person-centered care in sexual and reproductive health, right? What does that mean? Access is so important. We talk about it all the time, and we've been focusing on it, and I would even argue hiding behind it for decades, but that's insufficient without autonomy and equitable opportunity to make choices. These things are not mutually exclusive and can happen all at the same time. And so thinking very more concretely, excuse me, about what we can do, right? Or what we cannot do, really, right? I have a list here of what things we can't do, right? So number one, don't call the cops. Just don't. It happens disproportionately, and it very rarely ends well for most patients, most especially when people are pregnant. Think long and hard about calling CPS, or particularly documenting anything that would subsequently mandate you to call CPS. Again, CPS reports are disproportionate, and they bring folks into the system unnecessarily and almost always with unfavorable outcomes. Let's think about what we're writing in patients' charts that can be stigmatizing. We see this happen all of the time, right? These unnecessary patient descriptors about people's appearance, their clothing, their hair, their circumstances. Oh, they came late, they have an attitude, their family dynamics, like, oh, the father of the baby seems angry and overbearing. Think about the things that aren't necessary, that are disproportionately written in the charts of low-income people and people of color and LGBTQIA+ folks that don't need to be in there. Clinically, let's think about what information is absolutely necessary when, again, we're writing in the charts of people, particularly pregnant folks, right? G's and P's, or the number of pregnancies and their outcomes, we write those and talk about those all the time, but how necessary or important are they? Sometimes it's necessary to know how many spontaneous miscarriages people have had or how many preterm births people have had, but do we need to document every single abortion or all the pregnancies that people have had, especially if it's going to be a negative stigmatizing thing? Let's think about the things that we're writing in people's chart. We don't need to talk about what people do during pregnancy, um, um, or other actions that could stigmatize them. We have to remember that pregnant folks are highly criminalized and that they're often blamed for pregnancy outcomes in this country, even though we live in a country with the highest maternal mortality rate of all high resource nations. We blame it on patients when we know the causes are systemic and structurally racist and oppressive. So what can we do in healthcare to try to mitigate that? What can we do individually in our daily interactions when people are seeking care? I think I've said this 80 times, and I'm going to say it again. Understanding the historical context of violence and coercion and injustice and how it connects to where we are today and how it sets the stage is so important. We need to do the work to understand the context. It's a privilege to get to do that work, but it's not a one and done type thing. Like, okay, I went to a webinar or I read an article and now I know how to do this. This is a constant process of being able to provide person-centered care and understanding the context that we're doing it in, particularly for our marginalized folks. I also strongly think that this is all about trust and communication and letting the patient, the person who comes to see you, lead the conversation, because they actually do know more and better about their bodies than we do. It does mean that we listen and we believe and we trust people more, and we build the trust the same way that you would want it built for yourself when you're seeing a healthcare professional. It's not about expecting people to trust us, but about giving people a reason to trust us to begin with. I also think very much about focusing on patient preferences. Even though we say it, we're not always doing it. And we should be doing it in the context of lived experiences. We should be eliciting from patients their needs and wants and what they need, and then giving that to them. And that often means that you are talking less and listening more and judging less during your visit, and that's okay. It's important to talk to folks, give them the full information, and answer all of their questions truthfully and in a way that's evidence-based, the way that they ask for it, instead of downplaying things. That engenders trust. Respecting and supporting people throughout the course of your care as a family physician and a healthcare professional, and supporting people's choices, even if they aren't the ones that you would make, and even if it means that they don't want to talk to you about something and they're declining information, that's important. And lastly, and I think we're really all trying to do this, let's consider training and retraining and unlearning in comprehensive person-centered sexual and reproductive health. It's a process. It takes time, and we have to keep doing it. And I know all of this stuff seems really simple and obvious, but the data, the lived experiences, and the research is telling us that people are not getting this, especially in our marginalized communities. We are not delivering person-centered care. And now I will pass it.
Thank you so much, Dr. Carvajal. So I will quickly go through some of the systemic changes that could help us move closer towards racial and health equity and really deploy some person-centered care. Can you click?
I'm going to just interrupt for one moment here because we're getting so close to time. We have about 1 minute left. So I'm hoping that this is the beginning of a conversation and not the end. We're seeing some good comments in the Q&A here. Thanking you, Dr. Carvajal and Dr. Logan, for your great presentation, which I would really echo. And if you want to maybe, I know it's a lot to do, but maybe summarize this last slide and then think of a way that we could maybe get in touch with you if we wanted to further the dialogue or have other questions. And again, so appreciative of your presentation today and of the questions that you're asking and the work that you're doing in this area. So we'll give you a minute to wrap it up.
Thank you. So yes, along with keeping at the forefront of our minds racial and health equity, please also consider, advocating for universal health care, ensuring that there are some professional and national standards for person-centered care, and that this is, I think this is a conscientious, intentional process. There is no quick protocol, there is no summary sheet, There is no data to just download into your brain and then you do person-centered care. It is an ongoing journey that will take many of us healthcare professionals and public health professionals through the ends of our career. And so considering how to partner with communities, how to delve into the history, how to always apply a human rights-based perspective and a person-centered care perspective, and ensuring that the most marginalized among us are centered in whatever service, quality improvement initiative, or component or program of care that we're offering and designing is really the key. So yes, please reach out and contact us, engage with this material a little bit more, talk to people, and start considering what are the hard pieces that you have to start chipping away at in order to keep equity and justice at the forefront.
Thank you so much. I appreciate you ending us on that note, and thank you for a wonderful presentation today. Have a great afternoon, everyone, and glad that you joined us. Thank you.